Okay, I think we're going to get started. So welcome everyone. It's great to have you here this afternoon. My name is Jeffrey Mote. I am the Chief Executive Officer of Palliative Canada, and I have several panelists with me in person and online. To my immediate left is Dr. Megan Doherty, who's a specialist in pediatric palliative care, a consultant physician on the pediatric palliative care team at the Children's Hospital of Eastern Ontario in Ottawa, Canada. And among many other roles, Megan leads the Children's Palliative Care Initiative in Bangladesh and directs the palliative care program for Two Worlds Cancer, I believe, yes. So welcome, Megan. And to Megan's left, we have Dr. Chris Piromalli, who is a family physician with a subspecialty in hospice and palliative care and the co-director of the New Mexico Palliative Care ECHO at the University of New Mexico. Welcome, Chris. And joining us all across the pond, we have Professor Max Watson, a palliative care consultant in Northern Ireland and director of Project ECHO at Hospice UK. And we also have Dr. Jose Pereira, who's a palliative care physician and co-founder and scientific officer of Palliative Canada. Before we get into our presentation, we'd like to take a moment to recognize that the land in which we are presenting to you from has long served as a site of meeting and exchange among Indigenous peoples, including the Haudenosaunee and the Anishinaabe nations. And we acknowledge and thank the diverse Indigenous peoples whose presence marks this territory in which peoples of the world now gather. By way of agenda, we're going to start with a brief presentation from Max and Megan on a bit of background in the history of Project ECHO. And then Max and Jose are going to talk about the evaluation frameworks that are being used currently to measure the impact of Project ECHO. And then we're going to get into the bulk of the presentation, which is really on how different groups have leveraged the ECHO model to build palliative care capacity in different parts of the world. So we have 4 international experiences here in Canada, the US, in the UK, and in Southeast Asia. And then we're going to open it up to questions, and at the very end, we'll share some resources as well, okay? So without further ado, I am going to just cover a couple of more administrative pieces here. So I've talked a little bit about who we are. There's no conflicts of interest to declare by myself or the panelists. In terms of learning objectives, by the end of the session, we hope that you'll be able to pretty clearly describe the ECHO model and its various applications in palliative care, describe the position that the ECHO program can do to enhance palliative care with benefits to patients, the healthcare system, and healthcare providers. And then, of course, drawing on the international examples that we'll be taking you through, describing the different resources, the processes, and the infrastructures that are required to host ECHO-related programs, the evaluation approaches, of course, that are being used, and identifying any potential barriers to implementation of an ECHO program. So we really hope this is going to be an inspiring presentation for all of you to consider if this is something that might work for you and your respective organizations. There are no CanMeds competencies that will be identified during this presentation. And with that, I'm going to hand the floor over to Dr. Max Watson and Dr. Megan Doherty, who will give us an overview and background history of the Project ECHO. So I believe we're going to start with you, Max.
Thank you very much indeed, Jeff, and thank you very much indeed for this opportunity of being with you. I'm sad that I can't be in Montreal with you. It's so good that the Congress is back, and I've heard it's been a really inspiring time. So I wish you well for the remainder of the Congress. And this opportunity, I couldn't have a better set of panelists from across the world to share with you something of the magic of ECHO. ECHO stands for Extension of Community Healthcare Outcomes, and it began when a hepatologist from Boston got fed up with the Massachusetts winters and moved south to Albuquerque, New Mexico. And he discovered that in New Mexico, people were dying from hepatitis C who in Boston were living pretty well normal lives because they got access to medicines. In New Mexico, getting those medicines to patients was difficult. Rural physicians were nervous about being sued because of the side effects. And so Sanjeev Arora had the idea. He made contact with primary physicians, said, if I supported you online, would you give these medicines? And within a fairly short time, the viral load of people with hepatitis C across New Mexico had fallen to the same level as in his specialist clinic in Albuquerque. His waiting list had come down from 8 months to 2 weeks, but the complexity of patients that he was being asked to see had shot through the roof, because now generalists, with his support online, were looking after normal, if you like, hepatitis C. And so the ECHO movement was born, and it spread rapidly to involve a wide range of different specialties, including palliative care. So ECHO is a worldwide movement involving some 4 million people now, an enabler and a methodology. Thanks, Jeff. So it's a very simple idea. Jose is an educationalist, and we know at the essence that of education, we learn most significantly together when we feel safe, when we feel valued, when we feel listened to. I had a very scary chemistry teacher that almost ended my medical career, but I loved my English teacher and I learned so much. And it's that place, that safe space where we learn best. Jeff. So the fundamentals of the ECHO ethos and methodology is all about melting the iceberg of ignorance, so that the manager also is aware of the close effects at the bedside, and there isn't this disparity of knowledge and expertise, but an understanding that we're all linked up. So the philosophy can be summarized in an all teach, all learn approach. When we move from hierarchies of knowledge and power to a networked approach, building communities of practice with trained facilitation, so that the loud voices are maybe dampened down, and the quieter, really important voices, you can hear them with good facilitation, creating adult learning loops, and that safe space to learn and to share, and really important dedicated IT support so that it goes smoothly, as we've got our support today, and dedicated admin support so that people get their CPD certificates and it all works going forward. Jeff. The movement, as I said, is a worldwide movement, approaching 900,000 learners, with approaching 4 million attendances, et cetera, across 800 hubs, 59 countries, extending, I think, to over 100 countries where people are participating. Jeff. This short little video is a summary of ECHO.
Project ECHO is a performance optimizer. Think of it as a high-speed internet connection for the healthcare system. It spreads new medical knowledge throughout the healthcare system, from university medical centres and other specialty care sites to the front lines of community care. Rather than information flowing in one direction, community providers learn from specialists. They learn from each other, and specialists learn from community providers as new best practices emerge. Under ECHO, community providers use video technology to participate in guided practice with specialist mentors. They acquire new skills that allow them to treat patients they otherwise would have referred out. Patients with complex chronic conditions get high-quality care where they live from providers they know. No waiting months to see a specialist. No long drives back and forth to get critical care. ECHO exponentially increases access to specialty care by moving knowledge instead of moving patients. Suffering and pain are reduced, and lives are improved and even saved. Project ECHO, changing the world fast. Join us at echo.unm.edu. Are you part of the ECHO?
Jeff. Jeff, can you move us on?
You bet.
So in summary, ABCD is using the technology that we're using today to amplify, to leverage scarce resources over communities, to share best practice, to reduce disparities. So what's happening in central Montreal is also happening in the remote area of Saskatchewan. It's about case-based learning to master complexity, so that we can really delve into the key issues which allow good care to take place. And lastly, D, databases to monitor outcomes so that we are evaluating and we're making sure that people get their CPD, and we're making sure that what we're about is actually achieving what we want to aim, because life is too short for us to do anything which isn't effective. And putting all these principles together, we get an all teach, all learn community. Jeff. So people say, well, my granny can contact her grandchildren in Aberdeen from Montreal. What's this all about, this echo? And we've seen, what's the difference between a webinar? Well, webinars, we've lived with webinars for many years, and through COVID, lots of webinars, really helpful, useful. Tends to be unidirectional. There's often a little bit of quick Q&A, but it's really usually predetermined curriculum, usually one and done. And yeah, it has a huge value. Whereas we've seen that echo is a movement, it's an ethos, it's a philosophy. It encourages learning loops. It's based on real-time experience with the curriculum and schedule and frequency guided by the guests. Who are the guests? The learners, creating that safe space to learn and share. So much more about a philosophy, an approach to adult learning. Jeff. So you could look at it in terms of 6 C's, the 6 C's of echo: convening, creating spaces where people want to come together to learn and share; combining, ensuring there's sufficient diversity so that there's real opportunity to learn across the network; building capability, championing methods so that people can work to their capacity; coaching, coordinating and connecting, and building this community, the 6 C's of echo. Jeff. So echo methodology models the behaviors of healthy virtual networks: structure and safety, respect, listening, facilitation, and effective infrastructure. In our world of so much polarization, having safe spaces where people can listen and be heard is really important, with the methodology to match the vision. Jeff. Because we've seen through COVID, the decrees, the design is often very different from the user experience. So work collaboratively together, and it's much safer in our unsafe world as we go forward into uncertainty, working collaboratively together. Jeff. This is the evidence that made the difference for us, the New England Journal article showing just how safe echo was in reducing the viral load across New Mexico. Jeff. And in Northern Ireland, we've just finished a review of echo and evaluation. If you just move that on, we've been running 30 echo networks right across the province in a whole range of different areas. And the outcomes from the evaluation, Jeff, if you can just take us on. These are kind of summaries of the key quantitative and qualitative data that we picked up in our evaluation: the importance of building communities of practice, of this safe learning space, of improved decision-making, collaborative problem-solving, peer support. It's peer-to-peer learning which changes your practice rather than the professor telling you what you should be doing, enhanced job satisfaction, and reduced isolation. I'm going to hand over to Megan at this point. Megan, over to you.
Thank you. Thank you, Max. So I think Max has really given us a vision of what is echo, how does it work, big picture, how did it start from hepatitis C. I want to hone us in on how we're going to use echo for palliative care. What is our experience of using it exactly for palliative care? How are there some unique features, and just really how it matches with a lot of what we do as palliative care clinicians. And I want to bring this and this be guided from this principle, which Chris and I have been talking about all week, which just this idea that there's this abyss of access to pain relief and palliative care. And this is from the Lancet Commission, that overall in the world, there are 25 million people every year who die with serious health-related suffering that needs palliative care. And yet there's such a mismatch. So many of them, more than half, don't get access to palliative care. And we know that 80% of them are living in low and middle income countries. And we're going to share our experiences on echo in those settings and how it can address a little bit of this gap. So I want you to take away from this part that palliative care is well suited to echo. It's not going to solve all your problems. It's not going to fix the fact that, all the things that are wrong with palliative care in the world, but it's going to help us get there. Palliative care has been integrated into lots of different echo programs around the world. Max mentioned in Northern Ireland and showed you that big diagram with all the different conditions where echo has been used. And often, palliative care is integrated into those. If you have an echo on cancer, HIV, chronic pain, mental health, tuberculosis, diabetes, all of these sometimes draw in some palliative care. And then there are many dedicated palliative care echoes around the world. And there's great examples in LMICs, low and middle income countries. And I want to just highlight those in South Asia. In Uruguay, they've published on their echo in palliative care. Africa-wide, and I looked to see if it was specific to a country, and it's not. It's an Africa-wide one, which is why I haven't given a specific country there. And then the ones that we'll share in higher income settings. And when I was thinking about preparing for today and what I would tell you about our experience of using echo and why has echo been so powerful for us in palliative care, I was reflecting on a few things, and I'm going to go over these 5 things, which I want you to take what Max has said about what is echo and how it works, and then mesh them with palliative care and how that works and what you know about that. And so these are a few common barriers that we sometimes see in palliative care that match well with some solutions that echo offers. So this idea of professional isolation, and Max mentioned about that in the evaluation that they did in Northern Ireland, that often we're alone and we're not that well supported, especially sometimes our community palliative care colleagues or people who are delivering in the homes. They're not always connecting with many other professionals in a day, and echo has given that experience to them of being able to link up and talk to people who are going through similar experiences. The idea of provider distress in caring for terminally ill individuals, and again, connecting and sharing those experiences with other learners. That idea of creating community, which is something we do so much in palliative care, and echo has that philosophy too, of like, how do you create a community of learners? How do we support and strengthen each other to do this work of palliative care? We're always facing limited time and financial resources for training, or just a lack of opportunities that are like really specialized in palliative care. And we see this especially in settings where resources are more limited. It's really hard to find the right training or get to it. And ECHO addresses that. It says, don't send people for training, have it come to them, have it go right to where they are in their communities. New Mexico, I haven't been there that many times, but it's very rural, right? This started in a place where it was really hard to reach all the patients. And so I think about using ECHO for places where it's hard to reach the providers because they're in isolated, remote communities providing care, and they can't leave the patients, leave that hospital to come to training, because then who's going to look after the patients? And that's especially true in settings where resources are limited across Asia and often in Africa as well. I often say there's no echo programs on cardiovascular surgery that I know of. There might come, but there's some features of the type of care that we deliver in palliative care that I think are well suited to echo. So a lot of what we do, we sometimes say is like low tech, high touch, right? Doesn't need a lot of specialized equipment, hospitals, ORs, anesthesiologists, all those things there. So you can train and empower people who are in more remote communities who don't have access to tons of like medical technology and all kinds of complicated things. So that's, I think, one of the things that really allows palliative care to use echo a lot. Often in palliative care, we say palliative care is everybody's business. So this idea that we are using an approach to care, and echo does that. It has this idea of democratizing knowledge and skills. They want to get that information from that hepatology specialist in the center in New Mexico out to those rural providers who actually see patients with hepatitis C. So that idea of spreading palliative care, I think it works really well through ECHO. And then the idea of coordinating care across locations. So we are thinking about how our patients in palliative care transition through home, hospice, community, wherever they are going to be. And ECHO, because you can connect with the people in all those locations, will allow us to coordinate care better. If we connect up and share cases and learn together, then we're going to be more likely to be able to refer our patients and connect up those locations of care for them. And that idea of respect and engagement, which is so central to palliative care and is so central to ECHO, that idea of all teach, all learn, listen, engage, recognize that everyone brings to an ECHO program their unique knowledge and skills. A few ideas that we've seen work well for sessions on palliative care, using a flipped classroom. So in a traditional ECHO, usually you come and you get a didactic session first, and then you talk about a case. In palliative care, people are really motivated. We've seen that we can give them a video to watch before they come to the actual live Zoom session, and then we can go into discussion sooner in the ECHO itself. A few challenges that I think are a little more unique to palliative care ECHOs is measuring outcomes. So in that study that Max mentioned about hepatitis C, they could measure viral load of patients whose providers were in ECHO. There's no viral load for palliative care. So it's challenging for us to figure out how much is this benefiting the community, the patient, the family. It just takes a lot more time and energy to do that, right? Obviously, if people are seriously ill, the amount of time they get care for is short, then it's hard to reach those patients and say, how much did your care improve? And then if you want to reach their family, sometimes they're really focused on caring for their loved one. They don't have time to tell you how much better their experience was because of their provider being in ECHO. So there's some really core challenges to always measuring palliative care outcomes, but these carry through to ECHO outcomes. There's the challenges of virtual learning. So I don't think we can understate these. ECHO does try to address these, but the content must be relevant to the situation where it is. And I showed this image that I took in the Rohingya refugee camps in Bangladesh. These are just these are not patients, these are just children in the camps. And just thinking about the idea that where you're teaching, you need to say, what are the medications that are available there? If it's a focus on medications, like it's for doctors and nurses. And because it's very annoying to have a whole didactic session in your ECHO on the use of morphine, and then everyone puts up their hand, or they start to talk after the session, and they're saying, well, we don't actually have morphine here. And obviously that's not an issue in high-income settings, but many times in settings where resources are limited, access to morphine is very, very limited. So thinking about matching your learning, your teaching, your program to what's available, and to the scope of practice of the individuals who join your program. So again, this happens is that the scope of practice of different providers is different in different countries, right? The tasks that are done by nurses in India are slightly different than what nurses in palliative care in Canada do. So making sure that this matches. And then we know from our experience surveying our ECHO participants, timing of your ECHO is so important. The language, if it's not their first language, if the teaching's in English and they're speaking another language most of the time, these can be barriers. And then technical challenges. I mean, we've all gotten good on Zoom, or even our grandmothers have gotten good on Zoom, I think, but there's still, sometimes the internet cuts out and, it's raining. Internet never works well when it's raining in South Asia. So these can be challenges. How much time do I have left?
You have another 2 minutes.
Excellent, thanks, Jeff. And lastly, I'll just talk about the barrier of recruiting and retaining participants. So if staff turnover is really high, like it is in humanitarian settings, and I'm drawing a lot of examples from this, then is your ECHO going to work? Because you're always getting new people. There's just a lot of cycling, and that can happen even in the settings in Canada and the US as well. And then defining and recruiting your target learners. So maybe you have an idea that you want to reach your ECHO to reach a certain group of community healthcare providers in a certain region, but are you well enough connected to them that you can reach them and say, would you like to join this ECHO, and will it meet your learning needs? Do you understand them well enough? And sometimes one thing that trips people up in ECHO when they're starting out is that they want to provide something that will reach everybody who needs to know something about palliative care. So they'll say, okay, well, we're going to focus on the doctors and the nurses and the pharmacists and the physiotherapists who's in the program too, and then it starts to get a bit too muddy. And so you really have to say, no, what our goal is our pediatric oncology nurses at these hospitals in Nepal, we want them to understand how they can provide basic palliative care for children with cancer. And then other people can join your ECHO and they can be part of it and they can listen and they will learn, but knowing that you have a core group and that's who you're focused on will help guide you as you're preparing. And lastly, The use of social media. So usually I think I have sort of a hierarchy in my mind of all the electronic things in the world. And social media is at the very bottom of this hierarchy. It's like, perhaps an evil for all of mankind, except for when it comes to echo. So this is the only place in my life I accept social media. It's a way that we can create and communicate and connect up our learning communities that we form on Echo. But Echo is just, a Zoom session every week, every 2 weeks. How do you connect beyond that? How do you continue that conversation that is virtual and digital? This is the role of social media in the world, I believe. So this is a screenshot of WhatsApp group. In India, we use WhatsApp. We make a group for each of our Echo courses, and this allows us to share resources, discuss cases, of course, always de-identified, share YouTube links, and just continue that conversation, which I think is the core of Echo, because the core of Echo is really that community of learners. And I was talking today to our colleagues at Palliative India. They're presenting some posters here, and she said, they've had 27 batches of one of their Echo programs, and each of them, those learners are still connected to each other on that WhatsApp group that they joined when they joined the course. So I'll hand over to Jeff to continue our discussion here about evaluation frameworks.
Great. Thank you, Megan, and thank you, Max, for that. I'm going to switch gears a little bit now and talk a little bit about some of the evaluation frameworks that have been built. So we're going to turn the floor back to Max and then over to Jose. Max.
Thanks very much indeed, Jeff. Great. I think Megan has highlighted the difficulties and the challenges, but also the opportunities of evaluating echo networks. Asking the right people at the right time, the right questions to find out the right information for the right reasons. That's not an easy thing to do. Some people kind of think it is. It takes time to really come to terms with evaluation. Jeff, can you move on? And what are we evaluating? When we started echoes in Northern Ireland, I think the government wanted our echoes to suddenly decrease the number of people attending outpatients apartments and number of people attending accident emergency. And we're investing and if you ask those sort of questions, very quickly echo programs will come to an end, because echo is about building relationships. There's a process that we have to go through, and when we're evaluating, we're never evaluating echo. What we are evaluating is each individual network and their own unique journey. And so, Jeff, if we move on with our evaluation, we've come to use the MRC, a logic model for complex systems. And that's really what an echo network is, an outcome-based accountability, which lays the foundation for the evaluation. So with our networks, we will ask them right at the beginning to say, what would be the key things that you want to get out of this? What would be important to you, make you feel that you have used your time? So we begin with the network. So they're not kind of rats in the laboratory being examined. They are participants in the evaluation in achieving what they want to achieve, working out their objectives, looking at the inputs which will be acquired to meet those objectives, how many meetings are we going to hold, and the sort of outputs that we can expect in relation to their inputs and the outcomes, longer term, shorter term, that we can expect. And we've had quite a bit of success using this sort of model based in large part because our networks, they really contribute to our evaluation tools. Jeff, here's an example from a nursing home echo logic model with your objectives, your inputs, your activities, your outputs, short-term and long-term. And it's a really useful process looking at it in terms of the evaluation, but also in terms of what actually you want to achieve with your network. Jeff.
Switching gears over to Dr. Pereira.
Over to you, Josie.
Thank you very much. Hi, everyone. And I'm streaming into you from Amsterdam, where I'm in a hotel room and just spent the last few days attending my daughter's graduation for a master's degree in global health. So making my way back to Canada tomorrow. on the slide, you see Palliative Canada's evaluation and research framework. But before I walk you through it and its different elements and explain what we have depicted here, I think there's some very important contextual information that that I first need to share with you. Palliative Canada started back in 2000, so it's been 22 years ago that we started it. But it had an important predecessor called PalCare EdNet, which actually started in 1997. So this activity has been going on for more than a quarter of a century. And interestingly, back in 1997, we used the internet, web-based learning, to reach out to rural-based physicians and nurses with that approach of palliative care is everyone's business and disseminating the palliative care approach and those core competencies, especially in Alberta, to make sure that our colleagues in rural and remote regions had those core competencies. And during that model already, we would there was a formalized curriculum, but there was also a case-based discussion, so clinicians could bring their cases, and we would use those to discuss and learn. And even at that time, the approach we used was constructivism. In other words, people brought their experiences, and we used those experiences to build on it. And since then, so from 2000, we've got our first funding for Palliative Canada. Over the years, we've trained well over 40,000 healthcare professionals of different professions across the whole of Canada, every single province, every single territory. On average, we're doing about 560 courses. Now, these courses are referred to as the LEAP courses, so Learning Essential Approaches to Palliative Care. And these courses are about disseminating those core competencies that we call the palliative care approach, about supporting interprofessional learning. And we have different versions of the courses. So we've got different courses for different care settings. So we've got a LEAP hospital, we've got a LEAP community, we've got a LEAP emergency department, LEAP paramedics, LEAP heart, LEAP lung, LEAP liver, etc. So there's a LEAP pediatrics, and in fact, Megan was the prompter of that a few years ago and helped us develop that. So there are about 21 versions of the courses. We also have a LEAP for leaders, healthcare leaders. And for almost each of those, we have a fully classroom version, and they usually last anything from half a day to 2 days or 3 days. We have a fully online version, which is usually flipped. In other words, folks learn some of the core concepts online by themselves, and then we bring them together in webinars. But our webinars are interactive, so webinars are not always lecture type of things. Webinars can be very interactive, workshop format using case-based, problem-based learning. And then we also have these hybrid courses where people learn online and then come into a classroom and apply what they've learned online. So we've published some of that work. So that's called the LEAP program. And Palliative Canada has, over the years, been disseminating, spreading that LEAP program across the whole country, and also being used in undergraduate and postgraduate education in the medical and nursing schools and the health professions. A few years ago, we said, okay, well, we got an opportunity to look at ECHO. So we went to read up the evidence, the approach and the evidence, and we're very impressed by that. But we also said we don't want to reinvent the wheel. So we've been doing this now for many years. How can we use the two to complement each other? And that's what we're going to be speaking about shortly in another part of this workshop. But that's just to say that Palliative Canada now has these two programs, LEAP and ECHO, and we use them we think very complementary. But we've asked the question then, moving forward, how do we assess this and how do we evaluate the impact? In order to do that, Palliative commissioned I'm professor of palliative care at McMaster University, and we have a team there called the Joshua Shad Research Hub, and we partner with Palliative. And so we got commissioned to look at the evaluation framework that Palliative Canada had been using over the years, which had included over the years the logic frame or logical framework, and I'd used other methods, Kirkpatrick's method or model. And we were asked to please review where we're at, look at what's happening, what's emerging in the field of evaluating educational interventions, and come up with a framework that we can use moving forward to evaluate both the LEAP and the ECHO programs that we run. So we started a whole process. I won't go to that in detail, but it included about 18 experts from across Canada, experts in evaluation, education, health sciences evaluation, and also some experts overseas. And after studying many, many models, at least 24 of them, including the logic model or the logical framework, we came up with this one. And so I want you to focus on the blue box and then the yellow box, because in essence, it's got two pillars. The one is evaluation of impact, which is the blue part, and the other one is the evaluation of implementation, and that's the yellow part. If you look at the blue part, we've basically adopted Kirkpatrick's New World Model, which is an updated version of that framework. And level one is reach and learner experience. How many learners, how many participants? Did it make sense to you? Did this resonate for you? So we use something called the Net Promoter Score. Level two is looking at impact on learning, on changes in knowledge, attitudes, comfort. Level three looks at behavior and drivers. So has the behavior changed of the healthcare professionals or the learners? Level four is impact on patients and the healthcare system. And for that, we chose the quadruple aim as our lens. Now, the quadruple aim comes from quality improvement. And those four aims, the quadruple aims, are one, improving the patient experience. Two is improving the quality of care provided. Three is reducing costs and increasing efficiencies. And four is the care provider experience. Now, that doesn't stop us from also using things like logic frames, because sometimes some of our funders in the different provinces require that we use that or other models. Then the yellow one is, and this is very important, especially if we're developing communities of practice. And so we're doing a lot of this work at the moment, or starting this work at the moment. And for the implementation, we use what's called the Consolidated Framework of Implementation Research. It's got 5 big domains with about 52 different elements within those domains. And we chose what we thought were the most pertinent, and they listed there. So when you're starting or maintaining or trying to grow an education intervention, you ask the question, what factors enhance uptake of the course or the program? What factors impede it? What strategies reinforce, encourage, or support implementation of what is learned? What works, and this is important, what works for whom, in what circumstances, and why? Because what may work in one country, or in our case, in one province, may not necessarily work in another province or territory. And then adaptability and affordability of the program. So that's the framework we're using moving forward. Next, please, Jeff. We've started activities using that framework to inform us and guide us. Now, that doesn't mean that we're going to be able to evaluate each of those levels each of the times. But clearly, we need a combination of activities to fully understand the impact, both in terms of the impact on the learners, on healthcare system, but also on the implementation. So in the first activity we're starting up, we are asking the question, how does our Palliative Super Hub support the several hubs that have now been set up? And Jeff will explain that shortly. And how do those hubs network with each other? What's the role of the Super Hub in terms of spreading palliative care across the country? And then the role of the communities of practice that each of them support. In our second activity, we're going to start the process of going to each of these communities of practices that we've set up, and Jeff will share with you shortly what those are. And we're asking participants, how did this change what you're doing? What are the facilitators for each of those communities of practice? What have been the barriers? Where are they in their evolution? What's helped them reach where they are, or what needs to be done to elevate the activity and the reach? Next, please, Jeff.
Well,
so I think at this point, I'll hand over back to Jeff.
Yes, that's right. Okay, thank you. Just got my mic turned on here. Thank you, Jose. So panelists, we're about 5 minutes behind, so we're going to pick things up a little bit, and the crux of the presentation is really to share with you some international experiences and examples of how we've applied this ECHO model in palliative care. And we're going to start first with Canada. What you see here on the screen is what we refer to as the Palliative Care ECHO project. This is about fostering communities of practice and supporting continuing professional development among healthcare professionals who care for patients with life-limiting illness. So before we get into description, there is another video to share, so I'll turn it over to our tech folks to start that.
How can you provide the highest quality palliative care to individuals with life-limiting illness and their loved ones? An important first step is acquiring the foundational knowledge of the palliative care approach through courses such as LEAP. But that's not where the learning ends. The Palliative Care ECHO project is an initiative that fosters communities of practice and continuous learning opportunities for healthcare professionals across Canada. Led by Pallium Canada and a network of partners from across the country, this project delivers learning opportunities that are free of charge and tailored to meet the needs of providers in a variety of healthcare settings. The Palliative Care ECHO project spreads knowledge and builds and strengthens connections among healthcare professionals and communities to ensure more Canadians can access quality palliative care where they live. Learn, share, and connect. Participate in the Palliative Care ECHO project by visiting echopalliative.com.
That's great, thank you. So I wanted to mention that the Palliative Care ECHO project is a 5-year initiative. It is funded in part through a contribution agreement from Health Canada. It's a project that began November of 2020, but really started out the gates in March of 2021. So it's still a relatively new project. And I don't want to spend too much time on this slide, and Jose certainly has touched on it a little while ago, which is the ECHO project is very much complementary to the work that we do with our LEAP products. LEAP provides that foundational training on the palliative care approach to healthcare professionals. And then Project ECHO establishes communities of practice, and we have 5 different community of practice, and I'll describe those in just a moment, that exist, as well as supporting the continuous learning needs of healthcare professionals. So you can imagine, how do we support those learners who take a LEAP course, for instance, after they've received their certificate and begin applying what they've learned? How do we make sure that we support them throughout their learning journey? So the ECHO project is very much complementary. It's not a prerequisite to take a LEAP course in order to participate in the Palliative Care ECHO project. It's strongly encouraged because we know that learners get more out of their ECHO experience when they do have that foundational training, but it's not a prerequisite. So I want to introduce our 10 hub partners. So these are hub partners that we brought on board over the past year and a half. And these partners are quite varied. When you see them, we have provincial partners, we have national partners, we have small regional partners. And that was purposely done so we could get a really good read in the first part of this project to understand how the model works for different sized organizations. Each of these organizations represents, in some cases, hundreds and thousands, in some cases, thousands of healthcare professionals through their networks. And what we do is we work with each of these hub partners very early on to determine what the palliative care learning needs are of the healthcare professionals who they represent, and then establish priorities, goals, and objectives to then begin developing the ECHO sessions. So as you can see here, we have provincial palliative care partners such as the BC Centre for Palliative Care, national partners like the Canadian Home Care Association or the Canadian Association for Long-Term Care. Our 2 latest partners, Covenant Health and Médecins Francophones du Canada. And then, as you see here, some smaller partners. The Canadian Society of Palliative Care Physicians is a new partner as well. So we're very pleased with the diversity, the size and scope of each of our hub partners. And I'm going to go into some of the specifics around the different ECHO sessions that both Pallium and our ECHO hub partners offer. So it's important to distinguish between the 2 types of ECHO sessions. We talk about these ECHO sessions. These are Zoom sessions. And we have ECHO programs that Pallium ourselves creates and curates for the benefit of all of our hub partners. And then there are echo sessions that are developed by the hub partners themselves, specifically for the healthcare professionals that they represent within their networks. Okay, so as you can see on the left-hand side, the national program offerings that Pallium presents fall into one of four buckets. It's either a community of practice, it is we have a journal watch series, we have a quality improvement collaborative, and then we have one-off standalone sessions. So the community of practice really is the crux of the Palliative Care Echo project. It was the main reason why we went ahead to move this project forward, because they do represent our primary knowledge sharing vehicles. And to date, we've established 5. You can see some of them here on the screen: community-based primary palliative care. We have one for long-term care, severe and persistent mental illness, heart disease, paramedic, and so on. That, as I said, is a very important part of our overall strategy. These communities of practice haven't been dictated by Pallium. Typically, what happens is there's a few individuals, healthcare providers, clinicians who step forward to say this is something that's a need within our network, and they take the leadership role to actually create these, and then we provide the support to get them off the ground and to help them move along. And I'm going to turn the floor over to Jose, who's going to talk a little bit about our Journal Watch initiative and our QI program. Jose, we have 2 minutes.
Sure. So very quickly, as an example actually of the communities of practice. So we learned quite early on in doing our LEAP Heart, which targeted healthcare professionals looking after patients with advanced heart diseases, that there was an interest, especially from palliative care folks and from some cardiology leaders in some centers, to integrate palliative care within those services. And so the community of practice was established to do exactly that. So we've got some folks across the country who want to integrate palliative care within these heart failure clinics, amongst others. And so that community of practice supports that. Through our LEAP courses, we learned a few things as well. So we have over 900 trained facilitators across the country. We've been training them since the early 2000s. And many of them do not have academic affiliations. So they don't have access to journals, but they want to be kept up to speed with the most recent and exciting stuff that's coming out of the literature. So we've set up the Journal Watch to support them, as well as to support learners who've done the LEAP courses before and wish to continue updating their knowledge in palliative care. So this is a journal watch. It's not a journal club, and the differentiation is a journal club. One takes 1 or 2 articles, and you do an in-depth critical appraisal. What we have instead for the journal watch is we've established teams. There are about 6 teams with the McMaster University Division of Palliative Care and the Queen's University Division of Palliative Care. And our colleagues, we monitor the journals and we pick up articles that we think confirm our practices or challenge our practices or way of thinking. And then through an editorial process, we identify the top 5 papers that we want to present using the webinar, the Echo platform, and then we turn those into podcasts. So we invite you to go to our website, pallium.ca, and you'll find the webinar sessions on these journal watches, as well as the podcasts. The quality improvement program was interesting because, for example, in our community of practice for long-term care, there were folks, palliative care folks in particular, and some nursing homes or long-term care homes, as we call them, who wanted to improve the palliative care they provided within those homes. And so they asked the question, okay, we've done our LEAP long-term care courses, we've learned those core competencies, how can we now transform the establishment, the facility, the home? And so we set that up. That community of practice, and so they started sharing between these different programs. Some of them, some services had really integrated, others were in the beginning, and that's how the community of practice is now helping to bring those up to speed. And in the course of that, they said, well, we should be using a quality improvement approach as well. And wouldn't it be great if we could do that? And so we had been working on what we call a quick quality improvement a quick toolbox or checklist to use to implement change in primary care practices. And we've now leveraged that to develop some quality improvement toolkits for long-term care homes. Over to you, Jeff.
Thank you, Jose. And then a number of standalone sessions. These are one-off sessions on specific topics that have been brought to our attention by our learners that we then develop programs for. On the right is simply a cross-section of the different types of our Hub Partners programs. I won't bother reading them, but as you can see, a very strong variety of different initiatives. These are all prioritized based on the learning needs of the healthcare professionals who they represent. Very quickly, because I know we're ticking away here on time, the progress to date has been quite outstanding with this initiative. It's about a year and a half into it. We have some 150 ECHO sessions that have been delivered, some 8,000 learner experiences, but over 10,600 views. So for people that register for an ECHO session, if they're unable to attend live, we have many that go and view the taped session afterwards. So we have a strong number of session recording views and some 730 downloads of the Journal Watch podcast episodes. And you can see the heat map here from around the world of where people are from accessing this content. In terms of some overall observations, very strong pickup and adoption in Quebec. The average participation rate for an ECHO session is 8 to 10 times greater in Quebec than any other province and territory in Canada. So it's quite remarkable. We're obviously filling a need. There is a very, very high demand for session recordings, in particular for PSWs. And the majority of our learners are registered nurses, RPNs, nurse practitioners, and physicians. Moving right along in terms of learner feedback, overall, very strong feedback from our learners, as you can see here on the screen, and we've just captured some verbatim feedback. Obviously, the content is meeting the learners' needs. We're also hearing from our learners that they're being able to put into practice what they've learned, or it's reinforcing what they've learned through courses such as LEAP. So strong engagement domestically and internationally. And so let's keep moving because I want to be mindful of time here. Some common themes that are emerging: gratitude. Just absolute thanks from behalf of the learners, the participants in these sessions, for being able to access these sessions. They've really been enjoying the speakers. The caliber of the speakers that we've had, we're blessed with incredibly smart subject matter experts that devote their time and energy to create the content. They love the ability to connect with others. We saw this especially during COVID. You know, the ability to commiserate and to understand what others are going through. That was big, and a desire to continue having more sessions. In terms of lessons learned, so in no particular order, we're obviously filling a need based on the demand, keeping in mind that we launched ECHO in the middle of COVID, and yet people were still finding time to attend these sessions and to make the time, if they wasn't live, to view the recorded sessions. I think it's important to understand what ECHO can do well and what it can't. I think we've made the clear distinction between a course like LEAP and what ECHO can do. ECHO isn't about building, those fundamental skills and knowledge on the palliative care approach. That's what dedicated courses are for. But we know that it does foster strong networks and communication through our communities of practice. Although ECHO sessions are free, nothing's really free, is it? It does take a lot of time, energy, and resources to pull this together. And that requires a dedicated team, both at Palliative, but also with our hub partners. They have to have a hub coordinator and resources to work with their subject matter experts to develop the content and disseminate that through the Zoom sessions. And then I can't emphasize enough the importance of the clinical champions in driving our communities to practice. As I said, they're the few that come forward, grab the bull by the horns and say, this is something that's needed, and we're going to drive it. And they're the ones that champion it and continue to refresh them and renew them. And the administrative coordination of the ECHO program. So again, just the importance of the hub champions within each of our partnerships. And then lastly, I understand, please visit echopalliative.com for you Canadians in the room that are interested in learning more about what's there. The content is all there for you to view, free of charge. Poke around the site, and of course, be happy to take any questions later on. With that, Max, I'm going to turn the floor over to you to talk about Hospice UK and the Project ECHO experience.
Wow. Thank you very much indeed, Jeff, and thank you, Josie. I think I would just like to pay tribute to LEAP and tell you a kind of a very different story, because what the story that we've heard is an organization which to me personally has been hugely inspiring. What LEAP has achieved over the last 25 years has been an inspiration to me. But that's such a big organization would then seek to get involved with ECHO is a very kind of a different journey from the one that I want to talk to you about, which begins with one individual hospice facing the issue of their specialist palliative care nurses needing support, and reading the article in the New England Journal and saying, could ECHO be a way of supporting them? So we came at it from one organization in a very small way, and that's where our ECHO journey began. Jeff. And so we began with that, and we ran an ECHO with our community nurses. We evaluated it, put it into the British Medical Journal, Supported Palliative Care. It was very well received. The government in Northern Ireland, where we've had huge problems in our health service and need to co-create and co-produce new ways of working, they saw what we were doing and said, well, could we work with you? Would you run 5 networks for us and evaluate them? And we did that for a year. And they said, well, would you do 19? Yeah, we did. And would you do 30? And we moved then to Hospice UK. And over the last 5 years, we've been running 30 networks across Northern Ireland in a whole range of areas in which we can sprinkle a little bit of palliative dust, but we're also delivering in a whole, we're going to see next slide, Jeff, a whole range of areas like eating, drinking and swallowing, prison health care, social care council, linking up hospitals with their community teams, a range that we facilitated the running of the networks, and we received the money from the government to run the networks. And this has been really beneficial to us from a palliative care perspective in building relationships and also demonstrating, I guess as palliative people, we're really good at ECHO because we are facilitative. We are people who work in MDMs, which is in many ways is what ECHO is online. Jeff. And we moved then to Hospice UK, and currently Hospice UK is running 6 ECHOs across the UK, including the clinical ECHO, which I'm going to talk to you a little bit about, business continuity, linking up all the 260 different hospices for them as they deal with their finance issues, outcome measures in practice as we evaluate our hospice services, infection prevention and control, QI, and palliative care. And dementia. And yesterday we initiated a new ECHO involving 20 prisons from across England, linking in, looking at end-of-life care in prisons and bereavement care in prisons, with 70 participating, including governors and chaplains and other aspects of the custodial services, many of whom had never met with each other before, just bringing that community together to look at these issues. Just fantastic stuff. Move on, please, Jeff. Josie made reference to a super hub. A super hub is just, in ECHO parlance, it's a hospice. It's an ECHO hub which has had extra training so it can train other hubs. A hub is an organization which is running networks. And in UK, we work with 2 other super hubs in Highland Hospice and in St Luke's Hospice in Sheffield. And together we've trained some 69 hubs across the UK, 60 of whom are hospices. There's some over 400 networks running. And we've trained in Ireland, just recently a contract for rolling out ECHO to all the care homes across Ireland funded by the government. Jeff. Here's just the list of the ECHOs networks, of the ECHO hubs across the UK. You see most are hospices, but you also see increasing numbers of NHS organizations and universities embracing the ECHO methodology. One methodology, many visions. Jeff. Wanted to highlight the echo, which began with the coming of COVID. We had been running an echo support network for medical directors of hospices. COVID arrived and we transformed it. Jeff. So the Echo Clinical Network, it arrived at a time when we didn't know what we didn't know. We'd seen the images of China, and then we saw the images coming out of Italy. We knew this was coming towards us. What should we be doing? And so our echoes, they ran on a weekly basis initially through the first months of COVID. And we had 300 people joining the echoes, really representing a large proportion of the palliative care community across the UK. We summarized the latest evidence supporting practice, just like Josie and Jeff are talking about in terms of the Journal Watch. What is the latest in relation to COVID? The community asked questions. We fed those questions back to the NHS to get the answers and the information, which was vital. So there was this learning and sharing loop. The ECHO community allows for the sharing of key resources. So people were developing new ways of doing things and sharing that, which saved the reinventing of the wheels. The community shared, because alongside our ECHO meetings, we have a web presence where the resources talked about and the videos of the meeting are shared and the slides. And the community provided peer support and triage as to what is really important. In May of 2020, I think there was some 130 diktats sent in 1 month out to, for example, all the hospices. How are you supposed to cope with that? And the ECHO community helped to triage what was really important. The community changed the research paradigm. Researchers from King's and Edinburgh and others joined us. The network identified key questions that needed to be answered. The academics turned those into research. The network did the capturing of data. The academics turned it, give us the answers. In the course of a month, in the course of 12 months, the first 12 months of COVID, we published 12 articles. The speed, it was action learning, really relevant, a merger of clinicians with academicians through ECHO. And we began each of the sessions with the lighting of a candle, the recognition of the deaths, and we finished each session with a poem, just connecting with our humanity in the face of those awful days. It just it felt right. And it was our community, I think, at its best. Jeff. This is a summary. Nearly 700 people had registered. There were 19 sessions during that year. There were 4,000 people attended. The average attendance 217. And this is the website where the resources were stored. And in the chat boxes, people putting questions, other people answered them. So we called this the conversation, and we systematized it so people could go on and say, well, what are we doing about body bags? What are we doing about lateral flow? What do we do? And the community were answering their own questions, and where they weren't able to, we would get experts in to answer those questions. Really building on the ECHO methodology of everyone a teacher, everyone a learner. Jeff.
Wonderful, thank you. Max, for that presentation. We're now going to switch gears and give the floor over to Dr. Chris Piromalli. Chris, you have 8 minutes.
Okay, great. So I just wanted to share my personal story that'll just highlight how Project ECHO has been, in fact, impactful in my life in a number of ways. So as mentioned, I'm family medicine, and so my wife and I trained in Alaska in full scope family medicine. And Jeff, you can, sure. Thank you. So this is a picture outside of a plane looking over Western Alaska as I was on a medevac. And what I wanted to share with you, Jeff, this map shows you some of the challenges in Alaska itself where we trained. As you see, Alaska is the largest state in the United States, and the landmass that the Alaska Tribal Health System, which I had the pleasure to serve and be a part of, as you could see, there are over 250 villages across Alaska, and most of those villages are not on a road system, and so therefore you have to fly or take a boat to get there. And so what's amazing, the heroes of our healthcare system up in Alaska are community health aides who have, since the 1970s, been trained to be able to provide care. But one of the things that I would share, and this is the next slide, is just to say that serious illness, when a patient and family go through serious illness in villages, it often means that they're medevaced away from their home and their culture, and they're sent to Anchorage, Alaska, at the Alaska Native Medical Center. And so during my training, it was amazing to be a part of these medevacs, but kind of what haunted me later is the fact that were goals of care discussions had, and there was such a lack of palliative care throughout Alaska that it just really dawned on me something needed to be done. Well, my wife and I, we served, and we'll go to the next slide, and this just shows you, once the plane lands, it's a 30-minute, at this particular village, a 30-minute snow machine to get to the village clinic, and then to be able to medevac. So it's a big deal, especially since people are leaving their family and their friends and their culture behind. So my wife and I's first job was in Zuni, New Mexico, as a full-scope family medicine doc. And so you'll see in the next slide, New Mexico has a lot of similarities to Alaska. The tribal health system and Indian Health Service play a huge role in New Mexico, but it's very rural, and specialty care is very limited to really Albuquerque and the major popular metropolitan areas. So the vast majority of the state lacks a specialty care. Next slide. So one of the things was we practice full-scope family medicine here at Zuni Comprehensive Community Health Center. We serve the Navajo Nation and Pueblo tribes. We were about 2.5 to 3 hours away from any higher level of specialty or tertiary care. And the thing is, Project Echo was something that my wife and all of the providers got to participate in. We did deliveries, emergency medicine, we did inpatient care, and we also had our own panel of patients. I wore many hats. I was, even though not, officially trained, I was the palliative care medical director. And I was also, I was the diabetes director. But Project Echo allowed our patients to get the care in their hospital because people did not want to go all the way to Albuquerque. Often elders and even our pediatric population wanted care in their community, surrounded by their friends and their families. So Project Echo was that link that helped us to be able to be a part of a community so we didn't feel isolated, to learn best practices, and to get connected with specialists so that we could translate the care to the patients right where it was needed. And I just can't tell you how transformative that was. So much so that I decided to do a fellowship in palliative care. And we'll go to the next slide. And I went back to Alaska. And so the past 8 years, I spent my time in Alaska. And Alaska didn't have Project Echo. And so we started one of the first Project Echoes in palliative care. And it brought primary palliative care to our community health aides. It brought primary palliative care to our regional hubs to serve the Alaska Tribal Health System. And it was so transformative. In the interdisciplinary teams, it brought an interdisciplinary approach to these providers that felt so isolated and alone. And so it's just amazing to see how this model has transformed Alaska, especially with COVID, when the University of Alaska stepped up to provide care and create these circles of community and best practices for COVID-19. And so now I'm in New Mexico, and we're 4 sessions into our New Mexico Project Echo, because we hope to do the same throughout New Mexico with Project Echo. So I'm going to turn it over to my colleague, Megan. So.
Thank you, Chris. So I'll just wrap up. So when I was thinking about what to share with you today about my experience of actually implementing and doing ECHO, I thought I would select just one of the ECHOs and tell you how that has gone. I thought in the detail of that, I hope you find some interesting experiences that might translate back to how you take this to your own practice or wherever you are. And for this work, I want to acknowledge that I am bringing to you today the work of a huge number of partners and organizations together, most notably Two Worlds Cancer Collaboration, which is a Canadian NGO, and PRCPS, which is Pain Relief and Palliative Care Society in Hyderabad. So where are we? I think we're approximately where that little star is in Canada today. And this is where I want to take you on a journey over to India. And you can see I've put India, Sri Lanka, Bangladesh, and Nepal as stars on this map, in East Africa and the Philippines as well. So let's take a journey over there. We have 3 different types of ECHOs running there: adult palliative care ECHOs in the countries you see listed, pediatric ones, and humanitarian palliative care, which you may not have really thought of as its own thing, but I really do think that it is a unique type of palliative care that I have personally invented and delivered now. It's the first time you've seen it in writing. And who do we reach with our ECHO programs? It's very similar to what Jeff shared, what Pallium does. It's mainly nurses. There's some physicians. We have different groups. In different countries, you have different types of physician assistant or medical officer, which are sort of assisting physicians doing medical work, and other groups, as you see here. And I won't go through all of them, but we've delivered 24 different programs. But this is the one I really want to tell you about, which is for Rohingya refugee healthcare providers. So the Rohingya refugees were in Myanmar, and then they were forced to flee into Bangladesh about 5 years ago because of a lot of violence. So about 1 million people shifted into Bangladesh, into a remote jungle area where there were no cities, no roads, no services. So just imagine, like, how big is the city you live in? Maybe it's about 1 million, 500,000, I don't know where you all live. Montreal's a bit bigger than that. But imagine just all those people arriving. They are all illiterate because they've been really oppressed by the country they've been living in, so they're not able to learn to read and write. They're prevented from doing that. They've had no access to health care. They're unvaccinated because, again, these are all ways that they were sort of persecuted. And they just arrive and they're given material to set up tents, basically. And so you can imagine that there was a lot of need for chronic disease care. And the first steps that we did when we first were working in this area with my colleagues was just say, what is going on for individuals with chronic diseases? And these are some of the common ones that we identified and really were seeing there. And this report that's linked here tells a lot about what was actually the needs of these people. And we talked to them individually in their homes, where they were staying, in their tents, to hear about their experiences, which is the topic for another day's discussion. But this all led to an ECHO program. And again, I'm not going to say ECHO is going to solve all your problems. Jeff told you it's not. But you can target and tailor it to a few things that you need to do. So we identified a huge gap in that healthcare providers who were serving the Rohingya refugees were mostly Bangladeshi physicians, nurses, and other healthcare providers, and they had not had any palliative care training. But they were seeing all these individuals who were really sick, who had all these chronic and life-limiting conditions. And so we developed this ECHO program with what we call 10 core course modules. Some ECHOs would call this like a boot camp, where you're like, okay, we're gonna just deliver this like essentially a course where, you know, they come every week and you cover like 10 key topics. And at the end, if they complete those 10 modules, they join every session, they get a certificate of completion. And then we layered in, so we really wanted to stay true to this ECHO model, which really has the idea of mentoring and a sustained community of practice together. So we said, well, we can't just deliver this like boot camp where they come, do the 10, and then they leave and who knows where they go, because we don't think that's gonna change their practice a lot. We need to support them. Slides wanna keep going on me. It's probably a message. We need to support them, so we had these monthly mentoring sessions. So we did 14 of those in a year, so we kind of sandwiched them in amongst the 10 core sessions, and then we run them in between as well. And we said this can offer them some CPD and continuing ongoing support. So we've run this core course 6 times in Bangladesh and once in East Africa for humanitarian health workers there. And we have people who have joined every single course, the same people. And it's fascinating to me because I thought maybe they'll come, a few will come, we'll run it a couple times, and then we'll saturate the interest in this area. But every single time we open the registration for this course, we have 180 people sign up. So the first time we ran it in East Africa, we opened the registration. It was my colleague Erin was doing it, and she calls me really late in the evening. She's like, Megan, I don't know what to do. There's 200 people signed up. And I was like, just close the registration form. We'll deal with the rest of them after. So there's a huge need. People are just so much looking for something to support them. That's why they come each time, and that's why the mentoring continues to support them. These are the core modules. I won't go over it. It's the stuff that we all know is core to palliative care. I want to show feature our team a little bit just to illustrate for you that this is always highly collaborative, and Jeff spoke about that need for that core team who works really hard, who takes this on, who has this vision together. And you can see our team brings together Bangladeshi healthcare professionals, many of whom have extensive experience in palliative care, some clinicians from Canada, the US, and other places who bring that and have some experience in humanitarian settings or are really eager to listen and learn about those settings. So we all work together. Again, this leadership team also does the all teach, all learn, and we hear and listen and share together and develop this program. And I'm not going to have time to go over all of the experiences of what they have told us about the program, but I want to highlight this as the single one that I think really speaks to it. And these are quotes from some of the participants. So I actually feel that I am in a community. I feel we are sitting in one room. That's what one of the nurses told me. And when I saw the ECHO facilitator for the first time in Bangladesh, I didn't feel I was a stranger or anything. We knew each other for 1 year on the ECHO program. So it really does create this community, but it is about having faculty and leaders involved who are deeply engaged with the participants and learn to know them and listen to them as well. And I'm going to just sum up there by saying I think, this individual program with the refugee populations has really showed us that participants highly value this learning experience. It's about exchanging ideas and experiences. Every time I join, I learn something as well. But the main challenges that we've all seen in ECHO programs is helping our participants find time. So I always say your ECHO lives or dies by what time it's at. If it is at the wrong time, no one will come. And we learned this in our first year. We had it at 3 o'clock in the afternoon, Indian Standard Time, which everyone claimed was the perfect time. All the participants told me, this is when we want to join. And they never joined. And we had to understand how they practice, because they didn't even understand where is the gap in my day? When am I done with my outpatients, and when do I have a break when I can join? Or should I join before I go to work or after? And in the end, in India, the best time is like 7 a.m. or 8:30 p.m., even though they will tell you it's 3 in the afternoon. So I think that's really a key, is really understanding the workflow of the people you're working with and how you're going to make this fit into their day. And then technology I've spoken about, and language barriers. And I'll wrap it up there. And I'm right on 8 minutes, Jeff. So.
Wow, impressed. Thank you, Megan. Sorry you had to rush those last few slides. Very, very interesting. Just great perspectives from you, Chris, and of course, Megan and Max. Thank you so much for those presentations. I'm going to open it up now to some questions. We had one come through online, and I'll pose this to the panelists. Are any of the panelists running ECHOs with family caregivers? And anyone want to answer that?
Yeah, so I can't say I am, but I know that in Kenya, Aaron Das and KEPCA, which is Kenya Hospice Palliative Care Association, is doing a program that is for family caregivers, and I think for volunteers as well. So it is possible, it has been done. We have, so I think one sub-question of that,
Please, yeah, absolutely.
Is what about like community level health workers? Like in many settings, you have CHWs, community health workers, who maybe are in people's homes and doing some care, especially in low-income settings. And they weren't on my list. And I'll tell you why, is because it's mostly a language issue. So one thing about ECHO in LMICs, in low and middle income countries, is that often healthcare providers are trained in English, and they actually want to be having the teaching in English because their medical English is better than their medical, Hindi. They actually feel a little more comfortable to learn in English. And then so finding people who want to train at the community level in English is challenging often. And then the technology sometimes creates a barrier. Sometimes our community health workers, they would just prefer to sit under a tree together or in a courtyard together and really learn in a really face-to-face interactive style. So we haven't pushed them to do it on Zoom. But that's just our experience, not saying it's been researched at all.
One of our yes, go ahead, please, Max.
Jeff, we've worked on this with several networks, and we haven't cracked it yet. And I guess the reason is that family caregivers are normally really, really busy people. They live unpredictable lives. They're providing services to the person that they're caring for. And while they may want to be there, often they can't be there. And then there's the issue that family caregivers have all got different particular needs, and the benefit of being with others who are caregivers is very helpful from a supportive point of view, but the difficulty of getting a time and an openness is really helpful. We've run some where we've had difficulty in them not being dominated by one or two caregivers who just really couldn't get beyond just wanting to broadcast their story and their suffering and their issues, and that in the end wasn't helpful for everybody else. So we are still looking for new models of using ECHO for supporting family caregivers.
Very good, thank you, Max. Chris?
No, and one thing I would just share is there is a echoes for, of course, healthcare communities, but there's a whole group of Project Echoes also reaching out to educators. And so I would just say it's just exciting to see outside of healthcare how this model is expanding. We've mentioned prisons, but even in prison systems, they have, it's almost like there are these peer support groups. So they're training prisoners almost to be community health workers in the prison systems. And so I just share that with you to say that the model can really adapt to any different audience. It's just a matter of finding what the needs in your community are.
That's very good. Thank you, Chris. And thank you, Ross Taylor, for that question. Another question, how is the content of the sessions determined? Does anyone want to reflect on that?
So I think that's the big thing. In Alaska and then also in New Mexico, one of the wonderful models about Project ECHO is that everything is freely shared amongst different echoes. So one of the things is you're not starting from scratch. You're building upon other echoes and looking at the curriculum. But I think what's key is having a needs assessment, because every community is different. Every audience is different. And so it's really about adapting the curriculum to meet the needs of your community. Adaptability is also important because just because you've created a curriculum, what we've found is that topics come up. And what you thought initially your target audience is, it turns out to be something different. And so you always need to adapt and be able to put new topics, new curricula, based off of the feedback that you get from your participants. So,
thank you, Chris.
Jeff, could I come in?
Please. Yeah, go ahead, Max.
I think there's a spectrum. We've heard Megan talking about having a kind of an organized curriculum, and for some echoes that can work really well. We're really committed across the UK to the participants determining the topics in collaboration with, if you like, the experts. So we would have them work in breakout rooms to discuss what are the key topics that they would like on their curriculum. We would then come back and we would poll them using a Mentimeter or Slido. Very quickly we get a set of topics that we could kind of look at, which is their curriculum. It's not, because when we choose the curriculum, it's back down to that hierarchy. And give you an example of what was transformed. We were setting up a curriculum for care homes in South London, and they came up with this topic. They wanted to talk about racism. I thought, well, what racism in the care home, Echo? Why? Bottom line was the nursing population were Black. The patients had dementia, were white, were saying awful racist things to the nurses. And the nurses went, oh, what do we do with these vulnerable people who are being racially offensive? How do we deal with that? We would never have come up with that as a topic for our ECHO in a million years. And so working collaboratively together to create a curriculum is one of the powers of ECHO.
Thank you, Max.
Jim, can I just add that and actually just reinforce what Max said? So with Palliative Canada, over the years, so there's been over 22 years, the curriculum has been set up by a combination of methods. Initially was driven by focus groups from learners and the literature. And over the years, every course we ask learners, is there anything missing? Is there anything that's overdone in the curriculum? Is there anything that needs to be changed? And we use that to always modify the course as we go along. But every now and again, we come across a topic, like Max said, that there isn't time, or we can't do due diligence to the topic if we include it in a short course of 1 or 2 days, or even shorter or a bit longer. And so we've moved some of those topics into the ECHO sessions, where we can do deeper dives into certain areas. And we found that the ECHO really works well in that situation. For example, we're also looking at mental health. So we've just set a group, colleagues of ours, an ECHO session to reach out to palliative care folks across the country and some of their mental health colleagues, to start exploring what are the needs of these patients, and how can we then inform that. Then informs the creation of a LEAP course specifically for mental health. So like that, we use them very synergistically.
Thank you for that. We have a very patient person standing at the mic. Thank you so much for hanging tight there. Go ahead with your question.
No worries. I'm Dipti Mittal. I'm from Sydney, Australia. I'm currently working with a group of people that's trying to build a palliative care resource for the Pacific Islands at the moment. And through the process, we've discovered there's a lot of different organizations who are trying to do the same sort of thing. So I've got 2 questions. The first is, have you got any ideas as to how we can build collaboration so we're not constantly reinventing the wheel and just, pooling our resources, that we can actually not reinvent the wheel? And the second question is, I was quite taken aback about the 14 sessions in a 12-month period, because I've tried to run a monthly workshop for 6 months using Zoom over COVID, and it's been exhausting. There's a lot of preparation time, there's a lot of time to actually present, and then sort of the afterwork as well in terms of certificates, et cetera, et cetera. And you try and build a team, but everyone's really, really busy. And I'm just wondering, do you have any tips in terms of balancing your full-time work, life, home, and this work that, this developing work that you're trying to do?
Okay, panel, I'll open it up. Who would like to take the first part of
Could I go with that?
Of course, Max.
Just to say thank you very much indeed for your question. And I think the first part of your question is in part the answer to the second part of your question. If we can use ECHO as a collaborative process, and you get as many logos involved in the network as possible, as many partners who are committed to the overall journey as possible, wanting to own and work with the ECHO, then you also have a growing number of people who can share in the teaching load, who can share in the admin load, and work collaboratively together. I think, though, there are some core elements which are required in order to make an ECHO work. Running ECHO at 3 o'clock in the morning effort on top of a full clinical load, it's not sustainable. I know, I tried it. And you really need to have a commitment at some point from some organization just to provide the key elements, which are some admin support and some IT support, So I don't know what the other guys think. Sorry.
I think Jose wants to say something.
Jose, do you?
Yeah, I totally agree with Max. So, it's impossible for clinicians to do it on the fly and in between all the other responsibilities. And we've learned with Palliative Canada the importance of getting initially support from government to set up the infrastructures to support this work. And so we've got, I think, a really nicely oiled machine with under the leadership of Jeff that supports the clinicians to do this. It's so much easier with that funding and with the support. And what I've learned and observed as well is that the government is not always there to fund if you're turning to government. So early on, start setting it up as a social enterprise model, which Jeff has done very well for Palliative Canada. So it becomes self-sustainable to a certain degree, but we still need funding from foundations or from government to do some of the development stuff. And I want to echo what you, to use the term, echo what you said about reinventing the wheel, because Canada, for example, is a country with 13 provinces and territories, and within those many sub-regions, and there's always this temptation of reinventing the wheel, of an individual saying, "I'm going to develop a course," but it takes time. It takes a lot of effort. So my suggestion is reach out. For example, Palliative Canada, for example, there are a few others. They've already got ready-made courses that can be adopted, adapted, and then can be used through the ECHO platform and the ECHO communities of practice to help spread and disseminate. I think there's a lot of fantastic synergy here, which is what we are seeing. But you do need those resources and the funding. And as Jeff said, things are not always for free. It takes a toll. I remember for 4 years working on Palliative Canada to keep it going with no funding. It was, I'm surprised we didn't come to an end. It does take these resources.
Thanks, Jose.
I was just going to add one other thing too, is you can't do it alone. And that's why I would say all ECHOs really need an interdisciplinary team. And I would say on that interdisciplinary team, it's important to cross-train so that you have multiple facilitators, you have multiple people presenting, because then it's much more sustainable. But if you're trying to do it alone, it definitely would lead to burnout. So,
right. Anything to add to that, Megan? Okay.
Been there, done that. Yeah.
Our friend Kathleen Yu has asked a question here. I resonated with the idea of developing outcomes with the various communities. How then do you report outcomes for a super hub, i.e. supporting many communities? Max or Chris, I'm thinking. Any thoughts on that?
That is more difficult. And I think the kind of the meta research is more complex. And the Institute are looking at that. The Institute back in Albuquerque are looking at that. But our core element for evaluation is the individual community of practice, the individual network. And the indices that we've used in just looking at our success as a super hub is just really basic metrics of how many people are trained, how they respond to our training, how many networks they're running within a year of coming to training. So those are very crude metrics. Can I just mention to the lady from Australia, if she could she think about just contracting Perrin Moss? Perrin heads up the Super Hub in Queensland. He's at the Centre for Children's Health Research in South Brisbane. Perrin Moss is his name, perrin.moss@health.gld.gov.au. He'd be a really good contact because he's done it in Australia and he could give you some good guidance.
Excellent. Any other questions before we wrap things up? If we could go back to the slide deck, because there are some resources we want to put up on the screen for those that are maybe walked away thinking this might be something that you want to pursue. There are many resources out there available to you to help you begin your journey. So if we could put that back up, thank you very much. Any other questions, I should say?
And I would just add, like, if someone is interested, you know, the Echo Institute is very responsive, and they have whole training courses that are free, including Zoom memberships and all the other things that you might need. So they're there to provide support if that's something you're looking to pursue, and especially if you're wanting connections in a certain area, a certain population you want to target. It's all about collaboration, and so just going to Project Echo's website, you can get connected. So,
wonderful. Thank you, Chris. A big thank you to our panelists, Dr. Megan Doherty, Dr. Chris Piromalli, Dr. Mats Watson, and Dr. Jose Pereira. Thank you very much for your time. Thank you to everyone in the room for your time, your attention, your great questions. It was a pleasure for us to present to you today. Thank you. Enjoy the rest of your conference.
Thanks.